intravenous stuff. I don't think there's time to talk about both. Hopefully I'll have enough time to get through what I've got on these topics. It's very heavily weighted towards the PE aspect of it rather than DVT. And really I'm just going to talk about the essentially therapies for it, for PE, and also a little bit about DVT. So for pulmonary embolism, the first thing that, to talk about is the classifications of it. And I'll talk about this as we go through some of it, but there is a definition, but the problem is that many times it's used differently in different studies. You know, the same words are used, and they're used to mean different things in different studies. So it makes a lot of this interpretation difficult. And there are other things that make it difficult as well. So anyway, massive PE, and this really the kind of document that sort of puts the exclamation point on this is what we ought to use these terms for, is this American Heart Association document here, and it's from 2011, so it kind of talks about all this stuff. So massive means essentially shock, but they had to have had, the definition is blood pressure less than 90 for 15 minutes. And, I'll talk a little bit about that in a second, but so that's what they say it is. And the mortality of that, it ranges, there's a wide range, but it's probably around 50% if you could capture everybody who has that. It probably has a 30-day mortality of about 50%. But there is a lot of range in the studies. Submassive is a term to be used for PE without this pressure less than 90 for 15 minutes, but it does have right ventricular dysfunction, which can be identified on echo. There's more than one way to identify it on echo. It's not clear-cut, absolute yes or no on echo, but when they have it, they have it. Sometimes when they don't have it on echo, they may still have trouble, which can be identified with high pulmonary pressures or elevated biomarkers. Most people don't get right heart cath for PE nowadays, so knowing the actual pressure is usually estimated on echo, but it's a wide range. When they estimate the pressure on echo, it's got a lot of variability. They'll tell you a number, but if you look at the confidence interval of it, it's got a wide range. So the pressure is 40, but it could be 20 or it could be 60 type of thing. These, again, there's a wide variety here because it's so hard to figure out who these people really are in the studies, but it probably has a mortality between 10 to 15%, and some studies make it look like it's more like 3% to 5%, but and it may be, but I'll talk about some of that in a minute. And then low risk, and what I put in parentheses here is what they're sometimes called in the studies. And again, the definitions are tough to nail down in some of the studies, but there's sort of some synonyms for the what they might be called. But then a low risk PE is they have a PE, but they don't have shock and they don't have RV dysfunction, and that probably has a mortality of around 1%, averaging everybody together. I'll start to move along a little faster, hopefully. So there are two societies that have made recommendations about PTE management, or probably more than two. The two most important ones, and of those, the most important one is probably the American College of Chest Physicians. This is the 9th iteration of their recommendations in 2012. And they recommend that for massive PE, defined as I just said, those patients should get systemic thrombolysis. In selected patients with what they're talking about is submassive PE with low bleeding risk, consider systemic thrombolysis. So a lot of sort of caveats there, but they feel like if there's a contraindication of thrombolysis or thrombolysis fails, then it's reasonable to try some sort of catheter-based intervention. And they specifically recommend against using a pulmonary catheter for this. What that's actually based on is a study from 1988 in which they were doing a pulmonary angiogram anyway to make the diagnosis because they didn't have spiral CT. and the nuclear medicine scans weren't as good as they are now. So they were doing it anyway to get an angiogram, and then they would leave the catheter, but they would just leave the catheter sitting in the pulmonary artery, as opposed to a catheter that would go across the clot and weep, somehow or another, weep medicine out into the clot. Well, all the blood, in the absence of a shunt, all the blood that goes through, in the body goes through the lungs. So putting it right here in front of the clot or putting it in a vein, it's all going to get to the lungs anyway. So having a catheter sitting in the PA doesn't make any difference in terms of delivery, and that's why that study showed no difference. But if you had a catheter inside the clot, maybe it would have a difference in efficacy. The American Heart Association, in the document that I just referred to, recommends essentially similar to the chest guidelines, that if they have a low-risk PE, you anticoagulate them. If they have a high-risk PE, you give them, or if they have the massive PE, you give them systemic thrombolysis. And if they're in that submassive category, consider systemic thrombolysis. And if they have a contraindication or they have a failure, then consider doing a catheter thrombectomy or some other sort of interventional technique for them. Their recommendation for the catheter techniques are a little bit stronger, but still it's fairly similar to the chest guidelines. Just some problems with the data, with data interpretation. We all know shock is not defined as a pressure less than 90. You can have a pressure higher than 90 and be in shock, or have a pressure less than 90 and not be in shock. But it's very difficult to define that in studies, and then there would be just tremendous variability, and every study would be a matter of, well, did they really have shock or not, rather than did the therapy work. And particularly for PE patients, it's probably a better definition than it would be for sepsis or hemorrhagic shock or something, because typically what's happening there is it's cardiogenic shock, so typically it's going to result in some hypotension if it is in fact shock. But again, so not a perfect definition. And then there's all kind of variability. You'll see a study that says moderate PE, and you assume it's based on the clinical definition I talked about, but in fact it might be based on thrombus burden or the amount of occlusion of the pulmonary arteries, like the Miller score, or one of these other scoring techniques, or something that they came up with themselves to call it moderate. So in general, when you read these studies, you should look and see what do they really mean by moderate PE or submassive PE. There's also a lot of crossover in some of the studies. When we get to the randomized trials where they're randomized to either systemic thrombolysis or just anticoagulation, sometimes up to a quarter of the patients in the anticoagulation group after a period of time were given thrombolysis. And so it makes it very difficult to, certainly the earlier you get the thrombolysis, the better it is, but after 24 hours, it might still help. So it's difficult to interpret the results knowing that a quarter of those people ended up getting thrombolysis. So maybe that affected their mortality or outcome or whatever. And then the other problem is the what's called the composite endpoint. I don't know how much literature review, I'm sure you do a pretty good bit. And it seems like maybe in the last 10 years or so, there's been a lot more of this, quote, composite endpoint idea being used, where it's not just mortality or, a measurable variable, it's a combination of variables that I think sometimes is useful, but I think more often than not is used to get something significant when individually those things were not significant by statistics. And some we'll look at what they are, and some of them are kind of not too much compositing of things, where it's just maybe mortality and something else. Sometimes you'll see it gets a little out of hand. This is a chart from that circulation article that I was talking about that makes recommendations. I'll just put this up here to show the variability in mortality. The other problem here is that at least 4 of these studies have the numbers somewhat wrong up here. The other thing about it is to talk about registry data. If it's a registry that's dedicated to what it's supposed to be looking at, whether it's the disease or condition it wants to look at, if it's dedicated to that, that's probably fairly good quality data, although it's definitely retrospective because you put everything in there. It's not randomized, and then you just kind of look at all the data. But what comes out of it depends on how individual physicians or centers took care of the patients. And there can be a lot of variability or not much variability in that. And it depends on the granularity of the database, but a lot of times it's hard to tell. You know, for example, why was the mortality rate supposedly higher in this iCopper study for people who got lytic therapy with a submassive versus those who did not? Maybe it's because the thrombolysis killed them. Maybe it's because only the really sick people got the thrombolysis, and if you had randomized them, their mortality would have been higher than 21. Who knows? Another thing with these two studies that I've read all these, and they didn't separate the submassive, what I call submassive, which includes either RV dysfunction or elevated troponins or BNP or both. They combined all those with the people that just came in and had maybe even an asymptomatic PE. So 3% mortality is probably a little low, but who knows? And then this is the national inpatient sample, and I mean, it may be useful for some things. Typically, the way I look at it is if it supports my view, then it's useful. If it doesn't, then it's not. But at least in vascular surgery, in the journal, there's at least 1 or 2 articles every month that use the national inpatient sample. Partly because it's somewhat easy to just, type if you know how to do it, type a program and it'll spit out some result. The problem is, this is based on, there's so many levels of why it's probably not a good way to get data or really make policy, which is, our government and other regulatory agencies use this to make policy decisions. The problem is it's based on coding, and coding in the hospital is not done in order to make good data. It's done to get reimbursed by insurance companies and other goals. But the problem is that data is coming from a source that's not designed to give data to look at anything. So I'm highly suspect of anything that says national inpatient sample, and I think you probably should be too. All right, so let's look at a couple of these studies. So the first thing I'm going to look at are registry data, basically, or some sort of retrospective study. So the MAPIT-1, all these have these acronyms, and it's you take one letter from the middle of the word to provide something that's able to be pronounced. There were 204 German institutions. This is done by a guy named Constantinides, I think is how you say that. And he's done a lot of work in the pulmonary embolism arena. And there were 719 patients. They collected information about a lot of PE patients, but for this particular study, this data, they focused on what I would call submassive PE, which is normotensive patients with RV dysfunction or pulmonary hypertension by echo. 30-day all-cause mortality was 11.1% in the heparin group and 4.7% in the thrombolysis group. That did not reach statistical significance. Clinically, it sure looks to be significant. It cut it more than in half. But with an N of 719, it's hard to say that it's underpowered. But I think it was only about 20 or 30% that who received thrombolysis. It's difficult to know again, what the deal was. Patients who did not initially get thrombolysis, there was a 23% crossover. So the 23% of people who didn't get heparin, didn't get thrombolysis initially, ended up getting it subsequently during the hospital stay. So it's hard to know if this really is what their mortality would have been, or if it would have been higher. Major bleeding. This is where, if you read the textbooks, they usually say it's about a 20% risk of major bleeding with pulmonary embolism, with thrombolysis for PE. I'll show you on the next page what their definition was. 1% intracranial hemorrhage. Intracranial hemorrhage is definitely major bleeding, but I think some of that 22% is probably not major bleeding. And there was only one death in each group from bleeding. You can die from bleeding if you're just getting heparin. So here's their definition of major bleeding. Hemorrhagic stroke, sure, that's major. Decrease in hemoglobin levels of 2, maybe that's not major bleeding. I mean, if you came in, it was 36 and you were dehydrated, or you came in, your hemoglobin was 12, 13, you get hydrated and it drops to 10 or 11, I don't know if I would consider that major bleeding. Having to get transfused is probably significant. I don't know if I would necessarily call it major, but that's significant, having to get a transfusion. Retroperitoneal bleeding, well, to me, it depends how bad it is, because you can have minor retroperitoneal bleeding or major retroperitoneal bleeding. And And certainly if it required a surgical intervention, that would be major. And for the purposes of the study, it's probably good to include discontinuation of heparin or thrombolytic treatment. So anyway, just to summarize that, this study, it sure showed a lot of decrease in mortality, but statistically it wasn't significant, and there was a lot of crossover. This is one of the studies that the guidelines that recommend thrombolysis base their recommendation on. ICOPR had tons of had 54 institutions in 7 countries, so a wide variety of places taking care of patients. The 90-day mortality in massive PE was about 50%. Only it was 15% in quote non-massive PE. RV hypokinesis. So obviously the non-massive patients aren't all what I would call submassive because only 39% of them had RV kinesis, RV hypokinesis, and they did look at PA pressures and troponins and things, but it didn't reach 100% if you add all those up. And in the massive group, so people with pressure less than 90, only 60% of them had RV hypokinesis, and I don't know how to explain that, but there you have it. There were some differences between the groups. Of the massive patients, those who had low blood pressure, a fifth of them had CHF by history, so they probably already had a weak heart, and they had a PE, and they ended up being hypotensive. Maybe it's because they were all on hydralazine and nitrates and all the stuff that we're supposed to give them for CHF, but it's hard to know. But that was a statistically significant difference in terms of history of CHF. And then the other thing kind of interesting, I guess, is that the non-massive patients took longer to get to the hospital, which I guess makes sense. You know, if you're in shock, you're more likely to be sick to go to the hospital than if you're not. So again, it's all retrospective, registry-based stuff. But mortality rate, 90-day mortality rate was 46% of the patients who got thrombolysis versus 55% of those who didn't. But there were some significant differences in these patients. These are for massive PE, not submassive. Close to all of the patients that got thrombolysis had severe RV dysfunction or significant RV dysfunction. Hypokinesis, if you grade the severity of RV dysfunction, hypokinesis is about the highest. I guess akinesis would be worse. But hypokinesis is like the worst thing you can get. If it's dilated, that's bad. If the septum moves, that's bad. If the pressures are high, that's bad. But if they say hypokinesis, that just means your ventricle is kind of sitting there flopping around, not doing hardly anything. So that's a very significant finding, and that was statistically different between the groups. History of prior PE in the thrombolysis group, that's very significant too, because at least some of the patients who have a history of pulmonary embolism are going to have pulmonary hypertension and maybe some RV dysfunction at baseline, although it may be mild. So they're at a higher risk of having trouble. So all that is to say, maybe this, again, how do you interpret it? Maybe the 46, maybe if you hadn't given these patients with all these reasons to have trouble, if you hadn't given them thrombolysis, maybe, who knows, but maybe their mortality would have been a lot higher than 55%. That's a problem with retrospective data. You just have to look at what it is, but maybe there's a reason that things, maybe there's a difference. There's a reason that the numbers are the way they are. And then bleeding, 24%. A quarter of them had some bleeding. The explanation of what bleeding was in this study, if I remember correctly, was not very well described in the article itself, which is another problem with a lot of this data. But it was significantly higher than the no thrombolysis group, although they even had 15%. So there was no significant difference in systolic pressure in these, and I think it's just a single data point that they got in this registry, not an ongoing time-related thing. And there was no difference in recurrent PE at 90 days. I mentioned that because some of the studies, one of the reasons for recommending thrombolysis in these patients is that they may have a lower risk of recurrent PE down the line in some of the older studies they did. Everyone should memorize this, but I'm just showing you, are there any, a lot of times we talk about stuff and it's like, well, we don't really know because there's no randomized trials. Well, for PE, there are randomized trials for thrombolysis. Some are better than others. Many of them are quite small. I thought it was kind of funny. Some of these, like, this guy had 8 people. I mean, he randomized 8 people. 4 together. I mean, knew them by name. So anyway, I think you ought to check it out for like 10 people if you want to do a randomized trial, but maybe you live in a small town. But in aggregate, this is, it's, again, a lot of heterogeneity, but if you put them all together, patient by patient, and look at their bleeding and mortality and all of that, essentially it's a wash. There's a trend toward reduced mortality in people given thrombolysis, but it doesn't reach significance. So 70% would be the, 70% more risk of mortality.